All right. Hello, everybody. Sorry that you got to see me set up this recording, but I was struggling a little bit. Zoom was acting funny. So I figured it'd be easier if I just walked you through it with me. So this is one of the videos out of the 7 that you will be asked to view in order to participate in diabetes camp this year. This one in particular is called Managing Diabetes at Camp. You also will have one on general policies. You will have one on pumps and sensors, diet or nutrition management at camp, the infirmary, and I believe the last one is related to hypo and hyperglycemia management. So I think I said all of them. In the general diabetes management and policies, it actually has them all listed, and even the information about completion date and follow-up associated with these videos, because you will need to complete an attestation that you viewed all of the videos, and there will be a post-test on the content of the different videos. And I think your instructors might also be creating some type of question and presentation on the camp videos, just a summary and review at some point in time before your participation camp. At least that's what I had discussed with your instructors. So I am Angie Thompson. I am the camp director. So I have my certification as a family nurse practitioner. I am board certified in advanced diabetes management as a diabetes education specialist. I also am a fellow of the American Association of Nurse Practitioners, and I currently practice and have practiced in this particular location. It's called Hendricks Endocrinology in Danville, Indiana. So I care for adolescents and adults with diabetes and thyroid disorders. And I've been in that current area of practice since 2009. And prior to that, I was the director of the diabetes education program at Hendricks Regional Health. And so happy to be here. Happy you are here. I hope you, through these types of educational videos, will learn a lot about what the expectations are at camp and just kind of help you with your time at the camp. You'll have a lot of opportunity to review these videos. You can look at them or go through them over and over again if you feel like. If you feel like you've gotten everything you need just by watching them once, that's okay too. But it's definitely better than our in-person education program that we had before, where it was just one night that you had to absorb really everything that's in these videos. And so I think this format you'll definitely prefer over the old style that we used to use. So without ado, let me go ahead and start talking about the management of diabetes at camp. Just some medication policy data points I want to go over. All campers' medications, we really have to store them in a locked box at all times. And that's true of all medications unless there's refrigeration required. Certainly with insulin, it does require refrigeration. And so there are refrigerators within the cabin in your area. So in your medical staff area, that's where they're located at. So just an important point to make so that those medications don't inadvertently get taken by somebody or used by somebody. We don't really expect that will happen, but you always have to prepare for the unexpected. Each cabin, as I mentioned, has a fridge to store insulin and any other medication that requires refrigeration. Of course, if you've got a child who's on amoxicillin liquid formation, that has to be refrigerated. And that's a quick example I could remember, but I'm sure there are others. Medications that you get from the parents, they have to be kept in their original labeled container. So we can't have parents give us a weekly medication box with loose medications in them. We have to have them in their original form. And so if you get something that doesn't look like it's the right bottle or it's in that, feel free to just reach out to one of us as lead med staff and we can talk to the parent about it. I don't want you to feel uncomfortable trying to have that conversation. But every now and then that happens. And so parents just don't realize that it's a safety issue. The other things about our medication policy is that all medication administered has to be documented in our electronic EMR, and any changes to administration, particularly with insulin. You know, insulin, their regimen could be changed a couple times at camp just to prevent hypoglycemia, or if they're really having highs after a particular meal, then sometimes we will try to make adjustments so that they're not having those extreme issues occur. And so you want to document all of that in the electronic EMR so that we can track it throughout the week. General treatment guidelines. So the medical decision-making at camp is a responsibility of you as the student medical staff and me and the other lead medical staff. It is not something that the counselors or junior counselors or anybody else at camp should be dictating or directing you to do. And it's also not the responsibility of the campers. Now I say that, but I also really like to get the campers involved. I want to hear their point of view. They do have a right to voice their opinion, and oftentimes their opinion is taken into consideration, and sometimes changes aren't made if the camper has a different idea about what changes should be made, because sometimes they have really good understanding of their diabetes, and we shouldn't discount that. But I just wanted to make sure that you know that counselors, junior counselors, diabetes education staff, craft, the craft director, that they're not providing you with input and thinking that and I don't want you to think you have to follow it. Counselors are there to serve as resources. A lot of them have diabetes, so they will definitely provide you with their opinion because they've been a camper. They are now a counselor. They've had diabetes for a long time, and they bring a lot of knowledge to the table, but they're really not there to make medical decisions at camp at all. So I wanted to make sure I emphasize that because we've had a couple issues with that in the past. And our camp medical staff has felt a little bit uncomfortable being in that situation. So I want you to know that we're always here for you. So if that's kind of a scenario that you're dealing with, make sure you let me know or you let the other lead medical staff know so that we can address it. You always want to have your radio. You'll get a two-way radio, and that's like a walkie-talkie for some of us that are older. That's the term we used to use. But they are available for you to be able to reach out to any one of us. We use station 4 at camp, so it should be preset to that, but just make sure when you get it from the infirmary that you make sure it's set on station 4 so that when you need us, you're not trying to figure that out and troubleshooting it at that time. Because typically when you need us, you need us. You don't want to have anything get in the way of that. You also want to make sure it's charged and that it's working every day. So most of them, we have some that are have batteries, and we have some that actually have rechargeable batteries, and we keep the rechargeable batteries with us. So, it depends on which one you've got, but just, if you need it charged or you need a new set of batteries, let us know, because sometimes they don't last all week. The other thing that's important to know is that you're going to be getting iPads. We're utilizing an electronic EMR system. And so you'll have an iPad for your cabin, and you need to make sure they're charged every evening, and you will have a designated place to do that at night. But that way they don't die in the middle of the day unexpectedly when you're trying to chart insulin given or treatment for hypoglycemia. So in order to really understand a lot of the adjustments that surround insulin in a camper, it's really important for you to kind of have an understanding of a baseline of how the normal pancreas releases insulin in somebody without diabetes. Now, I know a lot of the pharmacy students already have a really good knowledge base in this, but there are many different types of medical staff students coming to our camp. And so it doesn't hurt to kind of review this a little bit. So with the natural insulin secretion, the body does release insulin 24/7. It's just the amount that can vary throughout the day. Oftentimes, the amount that's administered or released overnight is a very small amount, and it's a pretty steady amount. Now, that's in contrast to when a person consumes food, carbohydrates specifically, at their meals or even at snacks. The amount of insulin needed is much greater during those times to be able to absorb the glucose from the carbohydrates. And the more carbohydrates a person consumes, the more insulin they're going to need. So if we graphed it out as what you're seeing in front of you, it really depends on the composition of the meal and the amount of carbohydrates as to how much is released. So in this particular situation, this person ate around 8:30, and they had a really large amount put into the system, but not for a very long time. The body didn't need it delivered over a long time. So they probably consumed a high number of carbohydrates, but it was a carbohydrate that was easily absorbed. And so the administration of insulin tapered off pretty quickly. Now that's in contrast to when the person ate at noon, and then when the person ate at about 7 p.m., 8 p.m., this is military time, if you're not used to that. But at noon, they consumed carbohydrates, probably a little bit less, but it was in combination with fat, and that delayed the digestion a little bit. And so the delivery of the insulin was spread out a little bit longer than with breakfast. And the same with when they ate dinner, which was around 7 p.m. And then you can see that at the end of the evening, so midnight to like 4 a.m. and 8 a.m., it was just a small amount of insulin that was delivered every hour to help absorb the glucose that's sent or released into the bloodstream from either the breakdown of glucose in the liver or the production of glucose in the liver. So we try to mimic that, right? If somebody doesn't have a pancreas that is functioning, then when insulin is administered, it really needs to try to imitate this as perfect as it can. And so in order to do that, there's actually more than one insulin that's required. So this is a depiction of that same normal physiological secretion of insulin. So that's in the background, that gray. And then what you have, that black line and the turquoise type lines on here, are how we try to administer the insulin and which insulins take over which type of delivery. And so as you can see, that black line, that is either a long-acting insulin called Lantus, or it could be Levemir, Basaglar, Toujeo, Tresiba, and now there's actually Semglee that I have listed, later on when we talk about specific insulins. But these are all long-acting insulins, and so when a child gives this, then their body breaks down a small amount every hour, and so that mimics between meals and overnight the delivery that you would see when somebody doesn't have diabetes. So we call that basal insulin because that's their basal needs or baseline needs. And then there is a different kind of insulin that's administered at meals or snacks to help absorb the glucose from the meal, from the carbohydrates eaten. And some examples of that are Humalog, Apidra, Admelog, Fias. There's something called Lumjev now, and there is Novolog. So those are all types of meal insulins. And so the amount given is based on the number of carbohydrates consumed. Again, to try to mimic, what would be normally released. Now, we also have the option to administer this rapid acting insulin, the Humalog, the Novolog, the Apidra, Admelog, Fiasp, Lumjev. If glucose levels are elevated, then we could easily try to bring them down by giving additional rapid acting insulin. So oftentimes when insulin is given as a meal, it's to cover the carbs and correct an elevated reading that maybe was a result of not getting enough at the previous meal. And sometimes there's other factors involved, but just in a real quick review. So basal insulin, I already alluded to its purpose, but primarily it covers the body's metabolic needs when the person is fasting. And it keeps the glucose level relatively stable during that time, as long as there's not, sorry, I'm getting like a stink bug out of the way. So I apologize, but these freak me out. It's the saga of the stink bug. Okay. This is at my house, so you're getting all of me right now. So it should keep the glucose levels relatively stable under normal conditions. That can change though. If there's a lot of activity, then that basal insulin may be too much. If there's a lot of stress, it may not be enough. So there are times when that's adjusted accordingly. It can be delivered by an injection, or it can be delivered through an insulin pump. And if the camper has a pump, it's rapid acting insulin, and it's not long acting, it's rapid acting. And that rapid acting insulin is delivered tiny amounts every hour to mimic basal delivery. If it's by injections, usually the injection is given once or twice a day, depends on the kind of insulin. Some last longer than others, so some take twice a day regimens to get that 24-hour really pretty delivery. As I mentioned before, there's 6 different kinds. You've got Lantus, Levemir, Basaglar, Semglee, Toujeo, and Tresiba. Something to make note of, Tresiba and Toujeo come in 2 different sizes. So even though your pen that you have says Toujeo, you need to make sure you were given the right size. And the same with Tresiba. So whatever the child has, the camper has, coming in on their medical history, we need to match that with insulin. So you just need to double check. And I just wanted to give you that information, point of reference. So Prandon, bolus, mealtime insulin. As I mentioned before, it covers the carbohydrates consumed at a meal. And the way this is calculated, this is something that you'll be learning. Some of you will be learning at camp. Others may already have some familiarity with this. But basically what campers do is they're usually counting up all the carbs they're eating in a meal, or their parents are. It depends on developmentally where they're at. But the carbs are counted. So you get that total. And then you divide their insulin to carb ratio that the camper has into the total carbs, and that gives you the number of units that need to be given. Now, each camper has an individualized insulin to carb ratio, and some campers have a ratio for breakfast, a different one for lunch, and a different one for dinner. So you may see a variety of different carb ratios across the camp, but you just need to know what it is for your camper for that meal, and you'll have that listed all in front of you. So you're not memorizing anything. As I mentioned, for bolus or mealtime insulin, you've got 6 different options that will be available at camp. I've got a written example there. I know I said verbally some of the different regimens, but this is just an example of what you might see in that camper's electronic EMR about how they need to dose their insulin. And so in this particular case, at breakfast, they would use a 10 to divide into their carbs. At lunch, it would be 12. And at dinner, it'd be 15. And it's actually Novolog, not Novoloff. That's a spelling error in the PowerPoint. So let's do just an example so you have an idea of how it's done. But if you calculate or the camper calculates or you both calculate that they consume 50 grams at breakfast and their insulin to carb ratio is 1 unit for 10, then you divide 10 into 50 and you come up with 5 units. And so 5 units of their rapid acting insulin, in this case scenario, I chose Novolog, is what they would take for breakfast. Now, this doesn't count any additional insulin they may need to correct their glucose. So we're going to go over that next. So with correction dose insulin, this is the extra insulin you might give if their glucose level is elevated. And so the way that this is determined is that it's usually by a formula. That formula includes their current glucose. You subtract their current by their target. And then that number is divided by their sensitivity or correction factor. So these are one and the same. They're just two different ways of saying it. So you could have a camper that uses the term sensitivity factor or correction factor. Again, they're one and the same. It uses the rapid acting insulin, the same ones for meal dosing. And if we put this formula together, what we would be looking at is, let's say the camper's glucose is 200, their target's 100. So when you subtract that, you're going to get 100 points as the difference. So that's the top number of the equation. And then if their sensitivity or correction factor is 20, you would divide 20 into 100. And that means that they would need 5 units to correct this elevated glucose. So this 5 units is going to bring their current glucose of 200 down to 100. And oftentimes we are taking this correction dose and we are combining it with their meal. So if we use that scenario in the last slide to demonstrate that they need 5 units for a meal, the total amount that would be given would be 10. So let me just go over briefly the different types of insulin action profiles. I just think it's important for you to understand how they work, which is or how quickly they work, which is their onset, their peak, and then also how long they might be in the body, because this helps you determine if something's adjusted or not. And it will help you when you're looking at patterns to maybe identify if there's a particular pattern, which one of these might be the cause of that pattern. So with Novolog, Humalog, Apidra, Admelog, that also includes now Fiasp and Lumjev, their typically onset is very short. So with Novolog, Humalog, Apidra, and Admelog, it's less than 15 minutes. With Lumjev and Fiasp, it's about 5 minutes or less. So it's a lot shorter. So they are a much faster onset. They have this same peak though. So they are all the same peak as Novolog, Humalog, Apidra, and Admelog. So all of these 6 have about a half an hour to 1.5 hour peak, and they last about 3 to 4 hours in the body. So that's why the camper will need another injection at lunch and another injection at dinner, because the injection they took at the meal before is already gone. So they have a very short duration that they work in. Now, we rarely see NPH at camp. It is an older insulin, but if you have a camper that has NPH at camp, it typically only lasts about 10 to 12, 14 hours. Some can last 16. That's the packaging insert, what it says. But if this is used as a long-acting insulin, it has to be dosed twice a day, because it really doesn't provide 24 hours of action with one injection. So this is just a point of reference. It does take a couple hours to get in the system too. So there is, that's where the timing is also associated with that twice a day. It does have a peak, unfortunately, which is why it's kind of fallen out of favor with the other long-acting insulins, because you want to try to make a long-acting insulin not have a peak, because that's typically that basal metabolic need doesn't really have a peak associated with it. It's just a steady delivery. Then there's the Levemir, Lantus, Semglee, Basaglar, Tresiba, and Toujeo. They're all long-acting insulins. They do have a slight variation in their onset. So could be as soon as 1 hour, could be as long as 3 to 4 hours. None of them really have a peak. Their duration of action is slightly different. So Levemir is 24 hours as long as the camper, their dose is higher than 0.4 milligram per kilogram per day. You don't have to worry too much about that, but in let's put it this way, small doses of Levemir probably don't last 24 hours. So sometimes this is skipped twice a day. But Lantus, Semglee, Basaglar, they do last close to 24 hours. Occasionally we'll have campers where they don't, and they're dosing this twice a day, but it's not common. It's 10, 20% of people that are on these types of insulin. Tresiba and Toujeo, they fall into the ultra long acting. They do last more than 24 hours. So they provide a little bit more steady state than the Lantus and Levemir and Semglee and Basaglar. So we're starting to see those used more and more because they tend to have less risk for hypoglycemia as well. You know, those are up and coming, or they've been out a few years, but they're still not the majority of the camp right now. So the timing and the placement of medications, as I mentioned I think I mentioned this maybe in the general policies presentation, that non-insulin medications, they can be given at the picnic tables or cabin. And, you know, just defer to the EMR regimen that the child has. And so it's based on really the timing of when the camper needs the medication as to which one of those you would be giving it more in. The rapid acting insulin to correct an elevated glucose, it can be given before a meal if the camper chooses, especially if they have a pump, because you know, there's no injection associated with it. So a lot of times the campers want to correct their blood sugar then, and then they wait until after they eat to deliver the food bolus. And that's typically in the dining hall or at the picnic table. Now with kids that are on injections, oftentimes they don't want to have separate injections. So it's not unusual for them to defer the correction till it's combined with their food or meal bolus. And all of that's done after they eat and at the picnic tables or the dining hall. We really encourage you to deliver all the insulin at the picnic tables, because then for us as lead medical staff, it's very easy for us to go around and make sure your needs are met. If we have half the camp in the dining hall and half at picnic tables, it just makes it really hard for us to be there for you when issues come up. Now you are going to be helping with adjusting insulin. So we want you to be a little familiar about what things to look for, and then we'll guide you on some of those adjustments. So by no means will you be making those adjustments without assistance from one of us as lead med staff, but it is good for you to kind of know ahead of time what you might expect. And over the week, I anticipate that you will be a lot more knowledgeable and able to participate a lot more. And sometimes at the end of the week, you know, you are making all the suggestions and we are merely agreeing with them because you've really absorbed that much. But some tips for adjusting insulin: you want to look for patterns in the glucose. You want to look for the same patterns at the same time. And you really want them to occur at least 2 days in a row. It could be more than that, but typically you can see a pattern in as little as 2 days. So look for, you know, elevated numbers at the same time, consistently 2 days in a row at the same time. Or on the flip side, low glucose levels at the same time of the day, 2 days in a row. If severe hypoglycemia occurs, then we need to make changes right away. You don't want to wait until that cabin time or until, you know, swim time to meet with your lead medical and go over all the campers. So whenever severe hypoglycemia occurs, you really need to meet with them in a very short period of time. Treat the camper first, but then just call us on the radio or, you know, wave us if it's at the camp. If it's at the cabin, you know, at the tables, wave us so we can come over and make the change right away. But if just a pattern, it's not really disrupted their ability to participate in camp, but you notice that we probably need to change it at some point in time so that they can have a better camping experience and less likely that they're going to need treatment maybe later in the week. Then you can do that at the regular time when you're going to staff with your lead med staff. So what do you do about adjustments? Like what's typical? Well, 10 to 20% adjustment is really common if you see a pattern. So for the example, if you have somebody that's, you know, consistently got elevated glucose levels over 300 after lunch, you've had that happen for 2 days in a row, then it wouldn't be surprising to suggest or adjust their insulin up by 10 to 20%. And the flip side, if they're hypoglycemic. Sometimes the amount that's adjusted is even greater, especially if they're having hypoglycemia. Then it's not unusual to maybe defer to a 25, 30, 40%. So that's where the lead medical staff will look more at the camper as a whole, their overall control, any other medical conditions, and kind of guide you with their decision-making. You also want to discuss when changes are made, discuss it with the camper because you want them to feel comfortable with the changes. And if they have any fear about those changes, they're uncomfortable with those changes, that's an opportunity to discuss it more with them, give them an opportunity to voice what their concerns are. We can certainly help you with that. We don't expect you to navigate that conversation on your own. So make sure that you reach out to one of the lead med staff so that they can talk with the camper as well, and you can kind of see how that's handled. So I did want to go through a case study, and that way you could kind of see maybe how some adjustments could be potentially made. This is Colin. He's age 8. He's had type 1 diabetes for 2 years, so not very long. He's on Tresiba as his long-acting insulin. He gets 15 units every night. And here are his insulin to carb ratios. And he just so happens to have 3 different ones. He has 12 at breakfast, 8 at lunch, and 15 at dinner. His correction factor is the same all day. It's 58. And his target is 130. And so this is his electronic medical record documentation of his glucose levels by a blood glucose monitor. So he's not on a sensor. You're checking it at camp. And so what do you notice here? I want you to think about it. I want you to look at both a day's fasting, both days post-meal, look at the pre-meal pattern, post-meal lunch pattern, pre-dinner, post-meal dinner, and then bedtime snack to see if there's anything in particular that you've noticed might be a problem at camp and there might need to be adjustment made. So what I noticed right off the bat is that at fasting, his glucose levels are not necessarily hypoglycemic, but they're not really high enough that we would avoid hypoglycemia potentially at camp the next day. You know, his glucose level 79 and 80. And so coming out of a period of time where he's sleeping and he's not on a glucose sensor, so there's not going to be any warning if he becomes hypoglycemic, it would be important to possibly make a change there. The other pattern that I noticed was after his lunch meal, he was 65. So he did get hypoglycemic on the first day of camp. The second day of camp, he wasn't, but he was also in that low category. So if he were going to be participating in, say, pool time, he would get hypoglycemic if that was his glucose level heading into that high activity. And so these are the 2 areas I noted that really show some consistency. Other than, I will give you, if you've noticed that after his fasting, like after his breakfast, he was a little high. He was 231 and 194. But your most important patterns that you need to address are these lows. So not to say we couldn't come back and make a change there later, but you always want to fix hypoglycemia first before you do anything about anything else. So the cause, probably the fact that it could be he's more active at camp. And so those are just time periods where he needs less insulin. So it could be something as simple as that. It could also be that he's eating a lot more at camp and that he's getting a larger amount of insulin than what he would get at home. And so you're not seeing as much of a discrepancy in the dosing at home than you do here. So regardless, it looks like because of the way insulin's working, excuse me, at lunchtime, the cause of that is the dose taken at lunch. And so his insulin to carb ratio is 8. So that's most likely the cause. And I say that because if you look at his pre-lunch blood glucose, it was 167 and 104. So when his glucose was 104, he was not given correction. When his glucose was 167, he did have a little bit of insulin for correction, but because you have one without and one with, that helps you determine that it's really the insulin to carb ratio that needs to change, because that was relevant in both of those scenarios, whereas the correction factor was only relevant at one of the two. So that helps you kind of recognize the cause. And so I think changing the, insulin to carb ratio would be justified here. And if we did say the 10 to 20%, then how that would translate in insulin to carb ratio, and you get more training on this, but you would change it to 9 or 10. Essentially. So you actually, when you're trying to give less insulin, the number goes up here. So the opposite of what you think. Now for the fasting, really the only insulin in his system at that time is the Tresiba, the long acting. So that's how you know that that's what probably needs to change, especially since if you look at his bedtime glucose, is 155 and 156. So at that time, he could have gotten insulin for his bedtime snack. He may not have. I don't have that listed here. So that's something that you might want to consider. But in this scenario, I was mostly focusing on the long acting, and that the Tresiba of 15 units needed to be adjusted down, probably for the increased activity. And so if we did 10%, that would be going down 1 unit. If it was 20%, you're looking more at, 2 units. So could be changing it to 14 or 13 would be the recommendation. But keep in mind, in a different case scenario, if the Colin was getting insulin for his bedtime snack, then that could potentially be a cause as well. So you'd have to look more at his any overnight glucose levels taken and compare that to the bedtime and fasting to know if it's Tresiba or that bedtime insulin to carb ratio, which again, you'll learn that at camp. I just wanted to give you a real generic scenario for now. So activity, that's another area that significant adjustments can be made. In particular, if the camper is participating in moderate or high intensity activity, these oftentimes cause hypoglycemia. They're not always very active at home. Now, those kids that are participating in sports almost always have a setting in their pump or an adjustment that they use before they're going to be involved in that activity. And so that makes it a lot easier here at camp to use that ahead of time, to know that ahead of time, and employ that for prevention. But a lot of times these kids are not doing anything like that, especially with the COVID situation where, they've had schooling in a virtual environment and their sports have been delayed or modified. This may be the first time they're really this intense with their activity. Recommendations are always to check. We have this built into our policy that we do glucose checks before any moderate and high intensity activity, and then every hour during that activity. So evening activity can be an hour to 2 hours. It really depends on what it is. And so that's where you might do an additional check. But usually with swimming, it's just the check before. Unless they become hypoglycemic, then it would warrant more testing. The high activity at camp is mostly swimming. Nature walk is typically low. High ropes are in the moderate category. And the evening activity is almost always moderate or high. And that'll be announced every day, so you don't have to guess. With activity adjustments, you as medical staff need to notify us as lead medical if glucose levels before they head into that activity are 100 or below, because that's when preventative adjustments may need to be made. And so oftentimes we're adjusting the insulin preceding the activity. In some cases, there has to be carbs that are provided. So really the action depends on, well, first the camper's preference, because some don't always want to eat, or some love to eat, rather than adjust insulin. It also depends on their glucose history, what has happened when they've been active at camp, what is their current regimen, and any other medical conditions that need to be considered, like do they have a history of seizures when they get hypoglycemic? So in that situation, it could be more aggressive. So some common adjustments, if they're on an insulin pump, they actually have a lot more flexibility with adjustments. And so what can be done is their basal delivery can be adjusted down by 30%, sometimes up to 100% through a feature called temp basal. Or some pumps have a feature called exercise mode that the pump can be transitioned to, or we can disconnect the pump so they don't get any delivery. If the camper is on injections or pumps, they could actually have their meal dose preceding the activity lowered for prevention. And oftentimes it's lowered by 30 to 50%. So these are just generalities, but we definitely look at the camper individually to determine which one would be the best. If they're on injections or on pumps, carbohydrate administration could be included. However, it's less common with pumps because you do have the ability to adjust delivery on demand, whereas you really don't have that with injections. And so oftentimes this is reserved for campers on injections that they can consume 10 to 30 grams before, during, and sometimes even after moderate or high intensity activity. And so I did want to provide one case study just so we could somewhat go over this. So if you had Zoe and she's age 15, she has type 1 diabetes. She's had it actually for quite a long period of time, going on 8 years. And so she's on an insulin pump. She uses Admelog in that pump and she's wearing a sensor. So that's wonderful because we're getting tons of data points about what her glucose level is doing. And that sensor will actually look at trends and give recommendations based on that. And so, well, particularly what it will do is it will demonstrate the direction the glucose is heading and how fast. And if they, sometimes the pump and the sensor will then come up with recommendations. So with Zoe, she actually had yesterday evening hypoglycemia that happened late in the evening after the evening activity. And so based on that, because this happened after, she's on a pump, what kind of recommendations would you in fact make? So one of the options would be with an Omnipod. They do have the temp basal feature available. So we could reduce her insulin delivery by 50% when she's out there during the evening activity, bringing her glucose level up so that she's less likely to drop low late in the evening. So another option you may have thought of is reduce the bolus, the food bolus that she got at dinner by 30 to 50%. So that's a possibility. And then the third option is to consume 15 to 20 grams pre-activity as a prevention. And this is where you can certainly talk to Zoe and see if this has happened before, and her healthcare provider that manages her diabetes or her parents have already come up with a recommendation that works. You also, though, want to defer to your lead medical staff, because they can take all of that into consideration and help you with this. And so that way you would utilize that same adjustment for every high or moderate intensity activity for prevention. So I hope that this presentation was very helpful for you in helping you manage diabetes at camp. Certainly you're going to learn a lot on site that it's impossible to predict and be able to provide for you in this type of educational program. But you'll learn it on site, and you'll learn it together with the help of all the lead medical staff. Certainly, if you have some questions that have come up through reviewing this activity, feel free to email me directly. I've got my email listed. I also wanted to let you know that there are 3 Zoom Q&A sessions with case studies that are already scheduled. There's one on June 3rd, one on June 10th, one on June 17th. They're all at 6 to 7:30 p.m. The email for these links will be sent at a later time, but you are welcome to attend one of these sessions heading into your camp to just have a little bit of a review. Again, ask questions and go through some additional case studies that may be common or you might see at camp. So happy camping, and I will see you at camp.